Hello from SOHO 2019. My name is Owen O'Connor from Columbia University in New York, and I'd like to chat with you briefly about some of the updates for treating patients with relapsed or refractory peripheral T-cell lymphoma. As you probably know, over the last several years there have been a number of advances in T-cell lymphoma, most of which revolve around the approval of several new drugs, including pralatrexate, several HDAC inhibitors, as well as brentuximab vedotin for patients with CD30 positive anaplastic large cell lymphoma. And in addition to that, there have been several strides in understanding the underlying mechanisms of T-cell lymphomagenesis. And a lot of this data has pointed towards epigenetic dysfunction as one of the hallmark events in transformation of T-cell lymphomas. And over the last several years, we've now seen paradigms develop, paradigms that have been very similar to what we've seen for multiple myeloma. And these paradigms have involved trying to use these new drugs in novel combinations to try to develop new backbones that may be better than the CHOP or chemotherapy predicated ones that we use. I think it's important to realize that we've never really developed, other than some of the data for Echelon 2, we've never really developed any therapy for patients with T-cell lymphoma. Essentially, everything we do for the disease is derived from our experiences in treating aggressive B-cell lymphoma. So CHOP-based chemotherapy, first published from the intergroup study, had a minority of patients with T-cell lymphoma, but it was largely devoted to aggressive lymphomas. And even the role of transplant, which we take as a positive therapeutic modality in the treatment of relapsed aggressive diffuse large B-cell lymphoma, has questionable benefit in patients with T-cell lymphoma, or at least controversial benefit. And so I think we're beginning to turn that corner, where we're starting to now think about this disease as something unique. You know, we wouldn't be using lung cancer therapies to treat breast cancer, and we wouldn't be using colorectal therapy programs to treat ovarian cancer. But in essence, that's kind of what we've been doing in T-cell lymphoma for the last 30, 40 years. And so what's unique about many of the new drugs that we've developed is that they essentially have lineage selective activity. These are not drugs that work well in other diseases, not even solid tumor or B-cell lymphoma. And so over the last several years, our group and a variety of others have been developing translational programs to actually look at combining novel drugs that respect the established empiric pharmacology that we've seen from the approved agents and may well satisfy and target some of the underlying molecular defects in the disease. And what we're beginning to see is that even the doublets of some of these novel backbones, be it romidepsin plus pralatrexate, romidepsin plus azacitidine, romidepsin plus PI3 kinase inhibitors. The theme there, of course, is that the HDAC inhibitors seem to be a pretty important class of drugs for this disease, and as a single agent, may only have response rates of 25%. But in combination, we're now beginning to see overall response rates in the 60, 70, 80% range. And it's some of the data that we've produced in angioimmunoblastic T-cell lymphoma treated with azacitidine and romidepsin, published this month in Blood. We're seeing response rates in excess of 90%. In addition, we're also beginning to see gradual prolongation of the progression-free survival. And one of the great criticisms of some of the new drugs that have been developed in T-cell lymphoma has been, while they may have a reasonable overall response rate and complete response rate in patients with relapsed disease, the progression-free survivals have not been impressive. And what we're beginning to see is that combinations of these drugs is producing progression-free survivals that appear greater than what we see in B-cell lymphoma, owing to the lineage selectivity of many of these therapies. And so, for example, azacitidine and romidepsin. Azacitidine is a hypomethylating agent that directly addresses some of the hypomethylating defects commonly seen in patients with T-cell lymphoma, including mutations in TET2, IDH, and DNMT3. And these backbones, as we're beginning to learn, have very interesting effects not just on the T-cell lymphoma, but also on the tumor microenvironment. And it's paving the way to now think of what would be the third generation of clinical trials looking to develop new backbones in the disease. And these include studies that are going to look systematically at integrating immune checkpoint inhibitors like durvalumab and pembrolizumab. They're going to look at systematically evaluating drugs like brentuximab vedotin targeting CD30. And I think that the paradigm of developing an R-CHOP equivalent is beginning to emerge in T-cell lymphoma, except I don't think we're going to have the CHOP as the basic foundation for the future therapy. I think what you're going to see develop over the next couple of years, and it's going to develop fast, is that we're going to develop novel 2, 3, 4 drug regimens predicated on an epigenetic drug like a histone deacetylase inhibitor. And I think leveraging the pharmacologic effects of those drugs on the tumor proper and on the host to create a logic for adding biologic drugs like those that I mentioned before. So I think recognizing these are incredibly challenging diseases, rare and heterogeneous. We got a long way to go. And I think with the advent of most of these trials, we should really be thinking first and foremost about trying to get these patients on clinical trials wherever possible. And I think there's very little question, at least in my mind, that what we're seeing from these trials for patients with naive disease and patients with relapsed disease is going to rival what we see with chemotherapy, and I think in the very near future afford a whole new plethora of opportunities that is going to represent an advance over the current standard of care for patients with these very challenging diseases.